sequential doublets and triplets. Neoadjuvant chemotherapy. Patients in whom malnutrition is a significant or metastatic disease process appears unresectable may be treated with the neoadjuvant chemotherapy followed by interval cytoreduction and post-operative chemotherapy. There has been a significant movement in considering neoadjuvant chemotherapy for women who are candidates for even primary debulking surgery. URTC prospective RCT of 632 patients of Vergot et al. Demonstrated that neoadjuvant chemotherapy followed by interval debulking surgery was not inferior to the standard procedure. And the HR for death in patients assigned to neoadjuvant chemotherapy followed by interval debulking was 0.98, and for it was non-inferiority. Although post-operative rate for adverse event and mortality tend to be higher after primary debulking and than after interval debulking. And this study raised several controversies, particularly regarding the quality of debulking surgery. Importantly, complete resection for all macroscopic disease at primary and interval was the strongest predictor of independent value of predicting OS. And 41.6% patients were randomized to optimally debulk, that is 1 centimeter less residual tumor after cytoreduction, as compared to 80.6% patients with interval cytoreduction. Based on these results, neoadjuvant chemotherapy may be a reasonable option for significantly malnourished other patients, and including those medically optimized as well as unresectable abdominal disease, extra abdominal disease. MRC chorus inferiority trials showed no significant difference in either OS or PFS, and the authors concluded neoadjuvant chemotherapy was non-inferior to primary cytoreduction. The results should be interpreted with caution given the low microscopic residual disease rate in the primary surgery arm and identical medical surgical times in both the arms of 120 minutes. When the combination of carboplatin paclitaxel or carboplatin docetaxel is used for neoadjuvant chemotherapy, typically 3 to 4 cycles and given, and if there is a clinical radiological evidence of response, interval debulking operation is performed after 4 weeks to allow bone marrow recovery. 2 to 3 weeks after surgery, and patients can resume systemic therapy. 2 to 3 weeks after surgery, patient can resume systemic therapy with the addition of 3 to 4 cycles of chemo. Now, intraperitoneal chemotherapy. Post-operative combination of intraperitoneal IV combination chemotherapy for advanced ovarian cancer has been studied for phase 3 randomized control trial conducted GOG. Regional therapy takes advantage of both prolonged confinement of disease within the peritoneal cavity and steep dose response relationship observed for most cytotoxic agents. In addition, by exploring the peritoneal plasma barrier, the rate of drug clearance is slowed from the peritoneal to systemic compartment and creates a concentration differential favoring the peritoneal cavity. Although 2 previous GOG phase 3 trials in IP chemotherapy for ovarian carcinoma demonstrated significantly improved OS, they were escalation of IV carboplatin under the curve UC9 in the IP arm. For the third GOG study, Armstrong et al. Randomized 415 patients with no residual tumor greater than 1 centimeter after cytoreduction to receive paclitaxel 135 mg per meter square over IV, that is IV over 24 hours, followed by either cisplatin 75 mg per meter square IV on day 2 and the control IV arm or the cisplatin 1000 mg per meter square intraperitoneal on day 2 or plus paclitaxel 60 mg per meter square intraperitoneal on day 8. Investigation IP versus IV arm. Because paclitaxel is a relatively large molecule, so paclitaxel is a large molecule. The study team was concluded that without IV paclitaxel, systemic level of taxanes would be suboptimal if dependent only on the absorption of the drug from the peritoneal cavity, and treatment was repeated every 21 days for 6 cycles, and grade 3-4 pain, fatigue, hematological, gastrointestinal and metabolic neurological toxic events were more common with IP IV group than IV group alone. So only 42% of the patients in IPIV arm completed 6 cycles of this, but the median PFS in the IV arm and IPIV arm was 18.3 and 23.8 months. So quality of life was significantly worse in IPIV group before 3 to 4 cycles, before cycle 4, and 3 to 6 weeks after treatment, but not 1 year after treatment. So although IPIV therapy significantly improved POS due to high toxic rate, widespread adoption of this IPIV therapy for advanced epithelial ovarian cancer has not occurred. GOG Protocol 252 was designed to resolve the toxicity issue and validate the survival benefit attributed to IP therapy. Bevacizumab was included as both frontline and maintenance therapy in GOG 252. The 3-arm tested IP carboplatin, weekly dose dense paclitaxel, and a reduced intensity dose modified GOG 172 regimen. As a result, trial lacked a definitive control. The data were not interpreted. The survival data was not yet fully mature, but are unlikely to noteworthy given the negative PFS finding, and with the excess toxicity of IP route, the assertions of the biologics, there has been a decline use of IP chemotherapy.